Hey everybody. We're going to go ahead and get started. I do think some more people are going to be jumping on, but we'll get them introduced as we see them. We're going to start with introductions, and then I'm going to turn the time over to Dr. Swagger to give her didactic. If you guys have any questions, you can definitely chat those in during or save them for after, and you guys can talk. So we're going to start with introductions. Amanda, do you mind to start for us?
Hey everybody, I'm Amanda Newhouse. I'm clinical social work faculty here at WVU Medicine.
Perfect. Thank you so much. All right, and then we have M. Tolley.
Hey guys, I'm Marissa. I'm an LGSW at Community Care.
Perfect. Thank you for joining. All right, and then Katie.
Hi everyone, I'm an LGSW at Community Care.
Great. Perfect. And then Colleen, happy to see you.
Hi everyone, I'm Colleen Lillard. I'm a clinical psychologist at WVU.
Wonderful. Thank you. All right, Dr. Swagger.
Hey, I'm Lauren Swagger. It's so nice to see some new faces here today. I'm one of the psychiatrists at WVU. I specialize in child and adolescent psychiatry, but still see some adults as well.
Perfect. Thank you so much. All right, Brian.
Hi, my name is Brian Cisfasfel. I'm the Senior Operations Manager for Behavioral Health at Community Care.
Cool. Thank you so much. All right, John Cross.
Hello, I'm Mason Cross. I'm at LGSW for Community Care.
Great. Thank you so much. Let's see. We have H. Squires.
Hi, I'm a soon-to-be LGSW at Community Care.
Wonderful. Thank you. All right, and Kevin.
Hi, my name is Kevin Junkins. I'm a psychiatrist at Community Care.
Wonderful. Thank you for joining. And then Ashley.
Hi, my name is Ashley, and I will be an LGSW at Community Care.
Very nice. Wonderful. I'm so happy to have everybody here. Mara.
Hi, I'm Mara. I'm also a soon-to-be LGSW at Community Care.
Great. Thank you so much. And Mitra.
Hey guys, I'm Mitra Motasham with West Virginia Project Echo with Caitlin.
Wonderful. Thank you. Let's see. Dr. Sarah Hall just chatted in. Thank you so much for joining. Dr. Sridharan, do you want to introduce yourself?
Hi, I'm one of the pediatricians at MVA.
Wonderful. Thank you for joining. Well, I love this group that we have in front of us here. I'm going to turn the time over to Lauren because we're all super excited to hear her talk, and then we'll talk more at the end, everybody. Lauren, do you want me to share it and control it, or do you?
No, I think I got it. I've got my Zoom skills down a lot better. So
okay.
If I screw it up, rescue me, but.
No worries.
Well, it's so nice to see so many faces. Dr. Junkins, you did an amazing recruiting job getting folks here. Thank you. Dr. Junkins probably heard this talk several times in the past, so I have updated it a little bit if anyone has heard this before, but just before I pull up the screen, I just wanted to share a little bit of a background. So when I came back to West Virginia 12 years ago, I have seen sort of things evolve substantially with substance abuse in West Virginia, as many of us have, and sort of found over the years a growing need and a huge increase in percentages of kids coming into mental health care that had been exposed to substances in utero. And really very difficult concept to kind of wrap your head around. And so a lot of these kids were getting labeled with all sorts of psychiatric diagnoses and different problem areas, and really sort of sought to just understand it and realize that there's a lot we don't understand. So I hope as we talk about this, I also kind of give you a different way of thinking about how we conceptualize many of the challenges that these kids and families have, and ultimately really try to build on really good treatment that has to be very individualized often for these kids, but really trying to understand what that impact in utero may have caused to set these kids up for some of the challenges. And I think when you can kind of, for me, it was a lot easier to reframe and understand some of their challenges when I realized that sort of at the heart that their brains had been permanently changed, but not seeing that as also bad, because the beautiful thing about the brain is that there's all this resiliency and plasticity. And so with good and supportive interventions, you can really see tremendous growth. And so I have now cared for probably hundreds of children in utero exposed, and I've had some really phenomenal success stories too. And so I think sometimes people, what I don't want to have happen is people to think that just because they had this in utero exposure and all the problems that could be, that doesn't mean it has to be that way. It's just kind of a better way to understand maybe some of the difficulties they have and how to reframe sort of those interventions in an assisted kind of way to really address this as a unique underlying disability that really helps build them back. So hopefully it'll give you a way to think about it too. So and as always, I don't think I can see the chat very well when I pull up the screen, but I can't talk for half an hour without interruption. So please, please, please interrupt me with questions. I will lose my mind if you make me just hear my own voice for a half an hour, okay? So let me share my screen with you. Caitlin, it says that the screen sharing's been disabled.
Yeah, Zoom keeps updating and changing things on me. Give me 1 second. Try it again now.
Can you guys see that okay? Okay. So we're going to talk about, again, some of the mechanisms behind how this happens and sort of different patterns to explain the exposure effect and looking at the psychiatric outcomes that we know of. Most importantly, at the end, kind of talk about how multidisciplinary and multimodal treatments might really benefit and help these kids grow. So again, we're going to talk about all these substances. What I'll start with is going to be a very specific sort of backstory on what fetal alcohol does. And part of this is because fetal alcohol exposure is probably the best studied understanding of how a substance affects the brain. And we have far more information about the effects of alcohol. We are learning more about how individual substances all contribute. But of course, in this day and age, it is very unusual to see the effects of just one substance. And so many times now, the in utero exposure is really multiple substances, maybe hitting different things. And the frustrating part about this, and I think it will make sense as we go through this, is every kid ends up being quite different. If you think about development and the burden that occurs on the developmental brain, it depends on when the insult or the use occurred, during what stage and how much. And this child may have a very different pattern than this child if a different substance was used, a different amount was used, or different timing in the development. And part of that is because the brain is constantly growing. Many of the physical features we'll talk about are often earlier effects in that first trimester, but the brain continues with significant development, of course, all through pregnancy, and so the impact can be quite variable. And so this becomes a very heterogeneous exposure to kids. So when we talk about this, these are very generalized concepts that can occur. So how does parental substance abuse affect children? And we certainly know that some of these children are genetically predisposed to develop substance abuse themselves through the genetic mechanism. Most of what we're going to focus on in this talk is number 2. What happens in that neuroregulatory development of the brain when exposed? And then certainly after birth, there continues to be challenges from the parent's substance use. And many of you still see these things. So helping the parent cope with their own affect and response if they're intoxicated or still using or seeking substances continues to be challenges after they're born. We're not going to focus on that so much, but that of course becomes a huge part of treatment, knowing if the patient is with a caregiver that's using or not, and clearly changes the course. But for this talk, we're going to really focus on those early brain effects and what it ends up looking like. So I don't think I have to tell anybody on this call that this is a crisis situation in West Virginia. I'm not going to bore you with statistics. I have a lot more of them, but this is a serious problem. This is the #1 reason children are removed from homes in the state of West Virginia, and 80% of the children roughly are removed because of substance use issues. The kids are getting more complex physically and behaviorally, and in 2017 we had the highest rate of children removal sort of based on sort of statistic percentages for our population in the nation. This last number I have of September 2019, there were almost 7,000 children in an out-of-home placement in DHHR care, and you can see how those numbers have just really skyrocketed in the last decade. And again, the opiate epidemic drove a lot of these recent placements. We also have sort of the concept now that the person bringing the child into care may also be the grandparent of the child now, which lends a whole different dynamic, of course, to this discussion, because oftentimes the grandparent that's caring for their grandchild is also the parent of maybe the person having the substance abuse problem, and how complicated that is for them to mourn the loss and difficulties of their own child, or even the guilt of their own parenting. And so they may be really struggling as well with this, as well as coping with the effects of this grandchild that they're trying to do well by. And we certainly have one of the highest in the nation rates of this. So it's also very difficult sometimes to get a good history. And so sometimes when you see complex presentations, you certainly want to ask about this, but it's not an easy thing to do. And if the parent still maintains their rights, there's a lot of barriers to them to tell you the truth, because they don't want to be judged. They don't want to feel the guilt of having exposed their child. And so sometimes it's really hard. Sometimes DHHR gives you information. Sometimes the grandparent isn't sure. So sometimes it's really tricky to find out how much they used, when they used, or to really verify it. I've had the experience now of seeing some kids where and this happened to me the other day, where I had actually seen the child when they were younger in the care of their biological parent who had denied all exposure, and then later saw the same child several years later in DHHR custody or with a grandparent, and now the disclosure about substance use and exposure had really occurred. So it's very challenging sometimes to figure out. And if you think about things like meconium or urine drug streams, these can be such point of time testing that you can miss exposures. And there's some thoughts as we grow that the binge use of substances may be far worse than low-level uses of substances. And so we may miss a lot. And so suspecting it is important, but sometimes it's really hard to verify that exposure. So I'm gonna focus a lot on more of the later effects for this lecture. When you think about the effects on substances, you can think about it immediately. So if you think about like the concept of the neonatal abstinence syndrome, where babies are born addicted to opiates, or in those early stages about growth and mortality and weight and sort of obstetric care, that's what we call the early effects of the substance use. The late effects tend to start occurring around the time kids enter school. And this is where I'm going to focus this information on, because this is often what we're seeing in mental health. Often early on, you're seeing this in birth to 3 services, you're seeing this in neurology care, you're seeing this in pediatricians' offices, trying to just maintain physical growth and height and weight. But as the late effects occur, you start seeing the cognitive and behavioral outcomes. So you may see problems at school, you may see deficits in their learning and IQ, and certainly the behavior problems are what can be so frustrating to parents and make them present to mental health clinics. So we're gonna focus on the late effects. And I'm gonna start with alcohol, because as I said, it is the most well understood and documented and researched sort of syndrome. And you'll see that some of the themes from alcohol do translate to other substances. But if I can sort of reframe it for you, it's kind of understanding that these substances have some toxic effect on the brain, and they're affecting certain areas of the brain, and essentially destroying gray matter. So the children have very different brains and maybe less neuronal abilities from birth if some of those brain structures were destroyed in utero. So we have known about alcohol for decades. There are reports back in the 16th and 17th century about the effects of drink. They used to put pregnant women in debtors' prisons and sort of even show documentation that when removed from alcohol, the children born in debtors' prisons had better outcomes than those if the moms were were drinking. So these are certainly not new concepts, but in the 1970s, we finally got a clear set of diagnostic criteria looking at alcohol. And alcohol is probably more likely to be is probably the one substance that's more of a single substance effect, whereas as we have grown from this, we are certainly seeing more multi-substances exposures. So you have to also appreciate that this is not discriminatory in any capacity. This happens in every racial group, in every country, and they're pretty astounding figures with regards to this. We talk about the term fetal alcohol spectrum, and we talk about the term full fetal alcohol disorders. And so if you think about the full spectrum, where you meet full criteria, rates may be 1 in 100, approaching 1%. If you look at the full effect, if you look at alcohol disorder specifically, it may be much smaller, but the criteria are difficult because they're using both physical features and sort of the neurocognitive features. So this will make a little bit more sense in a minute. And these are some of the other sort of terminology that is used, but again, globally, this is just how we characterize in utero exposure. So you may see any of these terminologies in medical coding. So the physical effects are the easiest to document. The physical effects are usually the ones that have happened first trimester, when the brain, the skull, and the facial features are forming. So if you would happen not to have alcohol exposure till quite late in the pregnancy, you may not see any of this. But the classical features are, again, these very small epicampal folds where the eye openings are sort of, the palpebral fissures are quite narrow, and genetics will go in and actually sometimes measure this and plot it to see if it's normal or not normal. You tend to see sort of this flattened nasal bridge. Here, that little ridge that normally presents above the lip is sort of missing, and they describe that as a smooth philtrum. And then you can see this upper lip is hard to see, and that's sort of the thin upper lip that are sort of the most classical features of this. Here are some faces of children with known effects, and if you look at them subtly, you will see them, but they don't look grossly abnormal. So these are very hidden illnesses, right? We could have these children don't stand out as much as you think they would for exposure. They can still look quite normal, but if you again look closely, you will see again that very flat philtrum, very thin upper lip, and sort of these very smaller eyes with this wide flattened nasal bridge. They even can grade the philtrum. So if you think about this as a scoring guideline, and they have them for different ethnic groups, a 4 or 5 would sort of fit in the predisposed range of exposure. There are other odd things that people have noted. Again, these are all sort of resulted to neurological development, but the hand shows this hockey puck crease. Now, I will fully admit I actually have a hockey puck crease, and when I first gave this lecture, I was like, Mom, did you drink while you were pregnant with me? Because this is certainly not the only way that this occurs, but that is one of the findings. And then the secondary ridge on the ear is one of the other sort of findings that has been reported. The other things that clearly stick out are a height and weight below the 10th percentile. These kids have problems, are small for age. They have trouble making height and weight gains on their growth. They may actually show brain abnormalities where they have a very small head circumference. And these are the physical criteria that are used to make the diagnosis. So this is obviously easy when it's there, but what happens if a kid really has had effects, but you don't see it? And this is where the world of mental health sort of collides. So we've used these terms before, but all of this data and research uses these terms again. So I just want to make sure that we're all using the same language. You know, internalizing problems are referring to the mood, the emotional, the self-esteem problems that kids may struggle with. Externalizing problems are the ADHD, oppositionality, conduct disorder, aggression, the things we see. And as always, adults tend to see externalizing problems far easier than internalizing problems in children. But we have to remember that every internalizing problem can look like an externalizing problem, and every externalizing problem could be from an internalizing problem. And so to really understand the full effect is you have to actually interview and engage the child as opposed to just looking at external things. So this is where the story really becomes clear. I mean, this is on the left, a normal brain. On the right is a brain that was fully exposed to toxic levels of alcohol. And this child actually died, of course, because we wouldn't have the brain otherwise. So this is clearly a very sad case. But the challenge here is this is what substances do to the brain. If you think about the growing and developing brain, the area of the brain that grows the fastest, but also the last to develop and the most sensitive to either oxygen deprivation or toxins. And I don't know if you can see my printer, but this is the frontal lobe. This is the area of the brain behind the forehead. And if you see it, can you guys see my pointer? Okay, over here, you can just see how much smaller this region of the brain is, okay? And so all of these toxins, and this is going to be a pattern that plays out in almost any substance of exposure, all of these toxins are impacting the frontal lobe more than the other areas of the brain. These are also sort of, this is the gray matter part, and you have all these deep ridges. And when you have the neurons going into the brain and forming complex structures, you get more sophisticated thinking. If you look at this brain, you can see that neurons are actually dyed. It's very smooth. There's not much depth. This is brain death. This is brain loss. This is toxic effects. So again, this is a severe case, but these substances are causing brain damage. So these kids have less neurons, less neurotransmitters, less brain matter to begin with, and that's going to play a role. And depending on which area of the brains are affected, and at what time the substance use occurred, you may see very different patterns. So as we talk about sort of generalities on the next few slides about diagnosis and symptoms, you also have to remember that some kids may not have any of it. If that part of the brain was not affected, they might not have that. And so it's important important to understand that each of their brains may be quite different. Before we get into some of the more classical effects, does anybody have any questions for me?
Hey, Lauren, there was a question. You're welcome to answer it now, but if you're going to address it later, you can definitely tell us. So in an example where children are removed from birth parents, adopted, and access to birth parents is unavailable, what is the best option to determine exposure? In this case, is it safe to assume that mother was using during pregnancy? Is it enough to assume that there was in utero exposure? Or is there other testing that can be done to be sure?
So you may never know. There is some other testing, and this may be the one, this may be where neuropsychological testing can be quite helpful. Again, it may not confirm whether it was in utero substance abuse, in utero exposure or not, but it may categorize some of the specific neurocognitive things that impacted that child's brain. So you'll get a point in time sort of data point about what the outcome was. Now that's pretty sophisticated testing with neuropsychological testing, and that is even beyond what school psychological testing may do. So, and often, again, if we think about what the frontal lobe does, that can be a very subtle thing that comes out. So the frontal lobe is how we plan, it's how we organize, it's how we take visual information, hold it in our brain, manipulate it, and put it back out. The frontal lobe controls our self-regulation. So this frontal lobe area has projections everywhere. The frontal lobe is what makes us human. Okay, it controls our being, and it helps us regulate all the other aspects. And so when people talk about things like executive functioning, personality features, impulse control, sustained attention, this is the area. And so frequently on some of these testings, or even in clinical profiles, you'll see kids clearly presenting with these patterns, okay? And we'll talk a little bit about that. But the other answer is sometimes you suspect it and you just don't know. But even if you suspect it, doesn't mean there isn't some ways you can help address it. All right, so, you know, I think most of us, what we see, and this is, to me, the frustrated point, because I always want to know the answer, right? I want to know why the child's the way they are. I just don't want to slap on a label. but most of these kids are presenting, at least to mental health, with like 8,000 diagnoses. I think I saw a kid with about 18 diagnoses once that were psychiatric. And really at the end of the day, probably it was all the result of in utero substance exposure. And it just shows you how many aspects that it attaches. So, you know, we talk about reactive attachment disorder, the ability to love, connect, and feel attached to people. If you, and this isn't totally related to the in utero effects, but these children may have been neglected and not had stressful environments because of other factors related to the substance use. And so they tend not to be as attached to their caregivers. And this is a huge burden on understanding and feeling like people can help you that can be quite overcoming. And you clearly see that with parents that have heavily used substances, that 80% of children with heavy use of alcohol reported problems with attaching to people. Mood and anxiety is also huge, almost rates of 20% in children that exposed to moms that have had 3 drinks per occasion on a regular basis. And the key here is that 1% of this was in early childhood. You know, we are seeing much higher rates of depression, anxiety, and suicidality in very young children. When I came here 12 years ago, it was unheard of to hear kids at 10 or 11 commit suicide or attempt suicide, and now it is a very regular thing. And again, this is likely showing like the emotional aspect that loss of brain matter and self-regulation is contributing to. This is the one we see tremendously. Remember, I told you that frontal lobe helps regulate your emotions, helps regulate your mood, helps regulate your behavior. And so you lose that frontal lobe, you're gonna see ADHD features. And if you can't pay attention or focus, you can't listen, and people are gonna think you're not caring or that you're oppositional. And you're also more likely to be aggressive because you can't regulate your things. And again, this is probably all coming and stemming from that. Suicide rates are much higher. You can see the rates of suicidal ideations in children that are exposed. Again, this goes back to the genetic piece, but they're also at higher risk to go on to have substance use problems themselves. And there's probably a genetic sharing if their parent had substance use disorders, that they also are at risk to have their own substance use problems. And then here's the key. This is the key for schools. If you lose brain neurons, you lose IQ points. And so we definitely see kids achieving lower functioning academically and at a significant rate. And they're much more likely to be in the borderline or mentally impaired range than what would have been expected had they not been exposed. So this is something I have started using in my diagnosing. It is actually not officially a criteria though, and I want to make sure I say that. This falls under the category of DSM proposed criteria in the back of the DSM, and they're trying to validate this, but if you look at this and you look at what the definition actually says, you're going to see what these kids actually get labeled with. So they have impaired neurocognitive function, they have lost IQ points, they have intellectual deficits, they have problems with planning, organization, flexibility, and behavioral inhibition, they have problems learning, memory impairment, problems with visual spatial reasoning, which also visual spatial reasoning also plays a role in your ability to interpret features on people's faces. So you have social difficulties, you can't read emotion. You have problems interpreting, and there's been studies that show that these kids see more threat in the environment than they would have. They have problems in the ability to regulate their mood, their behaviors. They have attention deficits, they have impulse control. And so if you look at this, this describes children with alcohol exposure, think about what they actually get labeled with. So maybe someone could chime in, but what diagnoses in mental health are you gonna see these kids labeled with? Or all of them sometimes. So you may have intellectual disabilities, right? This is where you get your ADHD symptoms. This is your learning disorders. These sometimes look like kids with autism or social difficulties or social emotional reciprocity deficits. These are aggressive kids. These are oppositional kids. These are kids with conduct disorder. These are kids with depression, anxiety, ADHD, intermittent explosive disorder. You may see these kids labeled with, and again, sometimes they have been given every single one of them. And again, I don't know how, I think if you can go back and understand that, it's really important, because something like ADHD, if you inherited ADHD biologically, that's very different than this. Biologically inherited ADHD means probably that you're not responding to the dopamine at the receptor level in your frontal cortex. In alcohol exposure, you don't have the neurons to even release the dopamine. And this has enormous implications on treatment. And this also is kind of in the backstory of arguments about, is ADHD overdiagnosed or underdiagnosed? I don't even think that's the question. I just don't think we have determined the cause. And I think a lot of kids that get labeled ADHD or have lots of school difficulties, that may not be the biologically inherent part that we talk about, and then treatments don't work the same way, but really there may have been something more biologically driving that presentation. And so it's really an important thing to understand.
Lauren, I've seen this recently in the adult forensic world, and the individual was diagnosed with ADHD and bipolar. And I, after taking a look, really could see where they were coming from, but at the same time, all those symptoms that especially that second grouping of symptoms you were talking about with the emotion, dysregulation, impulse control, can get that label misdiagnosed as well.
Oh, absolutely. And then they're actually in true biologically inherited, there are overlaps between ADHD and bipolar disorder, but I didn't add that, but you're right, bipolar disorder, that mood dysregulation is classic, right? Like people just can't regulate their emotions. I mean, it really takes a very long history sometimes over time to even tease it out, because it's so much easier to talk about having bipolar disorder than it is to talk about maybe something you were exposed to when you were a kid. There's a lot more guilt and shame, and it's a harder conversation, but that's a really good point, Colleen. So again, this is just another slide that just really shows that looking at data, that when they looked at kids in foster care, that about 17%, and this was like nationwide. I would be a betting person and say that this is much higher in West Virginia, but I can't quite back this up, but this was these were some national numbers. All right, so we don't know as much about the patterns with other drugs, but we definitely see some similarities. Tobacco is one we forget about. When we're talking about opiates and people dying, we forget that tobacco is toxic. And West Virginia rivals Kentucky in the number of pregnant women who smoke. It is, I think, 28% of women in West Virginia are routinely using cigarettes during pregnancy, and even 10 cigarettes a day clearly increases risk. It says the same toxic and anoxic effects on the frontal lobes, and they are clearly showing elevated rates of ADHD as a result of that. Nobody ever talks about that when they talk about the risk of smoking with parents. We talk about sort of like growth and making sure you have good pregnancy outcomes, but there may be longer term consequences for that. And so a really big push has been to try to help women with tobacco cessation in pregnancy, because we clearly have higher rates. I think even if you look at like Medicaid data, we have higher rates of ADHD. And again, are we overdiagnosing? I don't think so. I think it's probably in utero exposure to tobacco, if not other things. Now, this gets people really going, and I'm not going to get into the political backdrop of it. You probably won't get many child and adolescent psychiatrists being excited about the medicalization of marijuana, because the impact on the developing brain and pregnancy is not good, and it is very hard to find much positive in it. And so I got interested in marijuana actually from a discussion from an OB who called me, who said to me, Lauren, I'm running this tobacco cessation group for a bunch of pregnant women, and one of the women just told everybody she gave up her cigarettes and started smoking weed, and it was so much better because it helped with her nausea too, and just convinced the entire support group to switch to marijuana. I don't know if that's a good idea or not, but I'm thinking it's not. And I was like, I'm thinking it's not too, and really kind of went into the literature, and we really are seeing some concerns ranging from that. And so again, if you look at these longitudinal studies that have looked at this, and again, none of these are perfect, and it's hard again to randomize or standardize this because of the risk, but look at what you're seeing. Higher rates of impulsivity, hyperactivity, delinquency, impaired executive functioning, right? And I have not seen it, but the Generation R study that should have had more data was supposed to do some neuropsychological testing as well, and I just have not seen those results come out to show that, but it clearly has an impact. Marijuana and IQ has clearly been been demonstrated about a 6 to 8 point IQ points. And if you think about standard deviation, that's half a standard deviation. My kids need their 8 IQ points sometimes. I'd like to be able to give them back. This is not a good thing to notice. Depression rates also seem to be higher as well, with much higher self-report of depression scales from children that were exposed in utero to marijuana as well. And this has nothing to do specifically with kids. I just think it's kind of cool how the brain works. This is actually, I think, a rat study where they even showed that there were changes in DNA and RNA that were passed transgenerationally, were affecting things like the immune response. So, you know, that really sets up for other health-related things, perhaps related to this. Again, I don't think anything beyond this has come out, but these are not isolated effects. So I was a child of the 90s, and everybody was using crack at the time, and people went out and said, oh, we shouldn't use crack, all the kids will die. And I think even the news report at one point had to come back and apologize because the kids didn't die. But this is what happened. Once they hit school, they started having problems. Okay, they had more needs for IEPs. They were having lots of problems with sustained attention and self-regulation. Their brain scans showed less of that gray matter volume in the frontal lobe, reward, emotion, memory, executive functioning, that same pattern of alcohol. But here's the key point. Look at this. Through 6 years, there was no effect on physical growth, developmental test scores, or language outcomes, right? That part was normal. It was all this attentional frontal lobe stuff that was really coming out much later. So to really do good studies, you have to follow kids through almost 20 years to get really good information. So this is going to really change the conversation with opiates, of course, going forward, is that we just might not know yet. Methamphetamine, clearly not great. Same things, right? Increased internalizing behaviors, rule breaking, aggression. And opiates are now trickling out. And again, we know much more about opiates regarding neonatal abstinence syndrome and those early effects. The information on the later effects is trickling out. And again, I don't think we can clearly say any of these things for sure, but the data is not looking good. And it's clearly following the same patterns of those executive functioning things in frontal lobe difficulties. So in looking in this one study, we are definitely seeing higher rates of disability, higher rates of school needs and IEPs. We're seeing cognitive decline. And look at this, 6% we have an IQ score 2 standard deviations. That's 30 points below normal compared to only seeing that. So 2 standard deviations is actually a definition of intellectual disability. So that's an IQ below 70. So 6% of kids were falling in that category as opposed to the normal rate of 1 to 2%. We're seeing bad motor outcomes that, and again, this is leading. So if you can't control your motor functioning, you can't control your executive functioning. They're connected. And here's the part, this part wasn't improving much after preschool. And it was actually getting worse. We don't know what the impact of early intervention may have, but if you don't address it early, there's not that opportunity for resiliency and growth. And I suspect there are going to be much larger issues. And this is a really hard conversation, and I just do not have all the answers either. But when we talk about opiate addiction, we need to talk about Suboxone and medication-assisted treatment, because it is the one sort of disorder that we have where we give people an opiate replacement in pregnancy to help their cravings. And I will tell you that I still am a firm believer in giving Suboxone to pregnant women, because the lowest possible dose that we can maintain someone on that doesn't involve the big binges is going to be safest for that child. The relapse rate of substance use in pregnancy without a medication-assisted treatment is less than 5%. So it's essentially not helping them at all and letting it continue. If I give you that Suboxone, you're more likely to get prenatal care. You're more likely to stay in treatment. You're more likely to bring your child with you to treatment. And we're stopping all the other drug-seeking behaviors and social emotional difficulties. And that's huge for kids too. But the part that I don't know, is there some risk in probably giving Suboxone on the brain? Probably. But is it better? I think so, absolutely. But this is a really hard conversation. If you get engaged in substance abuse treatment when you're pregnant, you're probably highly motivated to be a better parent and do the best that you can. You don't want to make the problem worse, but you can't say with 100% that Suboxone isn't causing something. But I think you can say it's a lot better than continuing to use. And if this medication helps you, then that will help your child. And really, it launches into this conversation that we with pediatrics and family have all the time. We have to talk about the risks, and we have to talk about the benefits. But we really have to ask the question, what's the risk of not treating that mom? Because the chances, if we don't treat that mom, it's going to be a whole lot worse. And that's always part of difficult decisions in pregnancy and kids. So if again, this is opiate exposure again, we definitely see that these neurocognitive difficulties have high risk stakes for our state. So lower score, school underachievement increases our risk of dropouts. You drop out, you're less likely to make as much money or be underemployed. There are higher rates of youth delinquency associated with those academic declines. You're much more likely to turn to alcohol and drug use anyway. That may drug use and alcohol use has been linked to higher crime. And we have overall higher burdens of healthcare costs. And if you think about that possibility of that intergenerational change that may be occurring in the DNA, as demonstrated by that one marijuana study, how is being a child with NAS going to influence your parenting when you become an adult, especially if you struggle with attention, focus, and attachment yourself? So the burden is enormous to try to overcome. But, and this is the really important part, despite all that terrible negative stuff I said, you can get success. It takes a village of multiple people and multiple services, but kids get better, and their brains are not forever that way. They can still grow and they can develop as long as it is focused in the right, healthy way. You can see people get better. And it's sometimes a long game for people, but it's so worth it. So if you think about how to approach these families in this comprehensive way, we absolutely have to make sure their parents, or whoever their current parents are, aren't actively using. If we don't stabilize that home environment of active use, we're going to add to that burden. So can we get the parents in their own treatment, or do they have a way to get help? We got to meet their basic needs. They have to be in a stable home life. If we haven't met our basic needs for eating, sleeping, we aren't going to do anything. So knowing that you have a secure family, a secure placement is huge. And this is what our system and CPS is desperately trying to establish right now, so that we can then add services on to fix the rest. There's certainly a role for, I know there are a lot of therapists on here. There is a huge role for psychotherapy and support to do PCIT, parent-child dyad work to help build attachment, help the parent feel like more effective at giving that child instruction. When you give a parent information about how to help a kid, you have to understand their difficulties. If this child has problems paying attention, parents can't yell across the room to tell the kid to do something. They have to get down at their level. They have to make eye contact. They have to tap them. They have to deliver modalities in multiple ways to get their attention. They require different parenting strategies. And that can be huge and empowering for a parent to realize how to best meet their kid's need. Individual therapy might be necessary if the kid has their own substance abuse problems or their own trauma they need to work through. Family part is key. And often there's lots going on in the family. And as I said, if they're grandparents or non-parental caregivers, there may be all sorts of family dynamics and guilt and things at play that are affecting the support system of this child. We have to think about basic needs again with physical health. Can they hear? Can they see? And language really matters. And I do mean language and not speech. Speech are the words that come out. Language is far more complicated. Language talks about the social understanding of language. Do you have, and we call that pragmatic language, do you understand the context of the word? And lots of kids, remember that those visual spatial centers can be quite impaired. The speech itself can be impaired. So they may understand the words, but putting it in the greater context of social emotional health may be a different challenge entirely. And we don't routinely do language screens. We routinely do speech screens. And it's a different assessment to be aware of. We have to think about medical needs for sleep, growth, and nutrition. Remember, these kids can be small for their size. Occupational therapy, speech therapy, physical therapy are really key as you build up motor functioning, as you build up speech, build up success and neuronal activity in its own right. School services are huge. Schools are really struggling with these kids. I think most of these kids deserve IEPs. They're going to have, so you want to make sure they're getting tested. The neuropsychological testing is always more complete, looking at some of the things, but just basic psychoeducational testing is a place to start, because some of these kids will have IQ deficits or math or learning difficulties that really need extra support and resources that they're not going to get in a school in a room with 25 other kids. And then probably the most controversial piece is what to do with medicines. And there is a place for medicines, but we can't over-medicate it. We can't add neurons back, but we have to make sure we understand the principles for this. So you can certainly use ADHD medicines to help some of the kids with attention and focus. There's some tricks to that, as Dr. Junkins, I'm sure, can attest, that if you give somebody too much stimulant and they don't have the neurons to handle it, they're going to get side effects. So sometimes you have to use much lower doses, or you have to use peripheral acting medicines like alpha agonists that can be much more helpful because they don't require all that brain structure to work. And then these kids struggle with depression and anxiety and may also need treated for those things with medicine. But at the end of the day, if you don't look at it comprehensively, no one thing alone will make them better. They really need an entire village to have that success. And the kids that I have seen be successful have received services in all these lines. And they can go on to live very healthy, productive lives with a hell of a lot of hard work. But it's the most rewarding thing I do to see those kids succeed. But it certainly is not easy. I throw up this slide again just for one more specific point, because this is the other risks that we see. We've talked all about kids, but the parents themselves have higher rates of mental health issues too. And this is a point that's coming out more and more, that parents actually have higher rates of psychosis from substance use. And if you see the big offender right here, marijuana, this is the fear I have for kids with legalizing things. And again, this is not everyone, and there certainly are risks and benefits to everything. But there are well-documented higher risks of psychosis from any substance in our caregivers. And it happens before the risk of the full association. So as we think about parents, we also have to think about the risk of reducing the burden of being psychotic on our children as well, and how we talk about this. And so when we think again about these large funded areas to really improve substance abuse treatment access, all of it helps children. This is my PALS line. I know I've shared this with you before, but this is the cell phone I carry, and the phone number that goes with it if anyone ever has a consultation question is available to any provider in the state. It rings to me most of the time, 8 to 4, Monday through Friday. Sometimes when I take a vacation, I give someone else the phone. But this is a service funded by Aetna Better Health for West Virginia. And I probably would say I've probably gotten 100 calls since the line opened. I would say probably half of the calls are actually the children have had some in utero exposure. So many these topics are often the ones we're discussing. All right, does anybody have any questions?
Well, that was wonderful, and I know we all enjoyed it because I've seen the chat. But everybody, we have about 10 minutes for questions. If you want to chat it in, I'll read it. If you want to unmute, you can definitely talk.
Well, I'm just going to give some of the statistics, so I don't have a question for you. Oh,
it's okay.
I didn't have a question for you, Lauren, but one of the things that you had brought up was the need for intervention. And I recently saw a presentation where the OT was reporting that only 10% of kids in West Virginia are really getting that early intervention. So it's much necessary, and there are a lot of therapists on. So I think that would be great to go in those different areas. And one of those resources that I thought I would share is To the Moon and Back. And that's a resource in West Virginia that helps babies and children and supporting the entire families for kids who've been exposed in utero. So
That's really awesome. Thank you, Amanda. One of the other questions was about getting the phone number for the PALS line. We'll send out the slides, and you guys will have that slide to pull the number right from, so you'll be all set. And and Lauren is muted, but I think she's chatting.
I'm gonna type the number in the chat too.
Perfect. Any other questions or any cases you've seen like this that you really thought about during this?
Hi, so I just had a quick question. Can everybody hear me okay? Okay. So I actually did my research project on NAS, and I had found that males were more prone to being affected by it. Have you seen a difference in gender?
You know, I have not specifically for opiate exposure. I would say that there's a lot of data on like sort of, there's always been some concern and that males were at higher risk for impulse control problems and more hyperactive behaviors. If you even look at ADHD data, that was, again, not the same, but there always seemed to be, and I don't know if this was sort of the protecting effects of testosterone or anything, but it also was we've seen some of that, and I don't know that I have a great explanation for that. I also don't think we have enough data points to separate it out. What I will tell you though is I think the tolerance for hyperactive and wild boys is a lot higher than the tolerance for hyperactive and wild girls. And I would say, again, I don't have data to support this, but the girls that I see that are super dysregulated seem to have a much higher burden of stigma and less tolerance. And I think there's a lot of cultural impacts on that, but you know, I don't know, but I think it's interesting. I mean, testosterone also, as people get older, and again, probably not so much when they're young, but testosterone is also a driver of aggression. And so we definitely know that as kids get older, that males with the puberty surge will tend to have higher rates of impulsive aggression compared to girls. But I'm not sure I can explain that very well younger, but I don't think it surprises me, but I also think it may be underreported. I think we don't always identify girls with mental health conditions as readily as we do with boys, especially with some of the externalizing things. And there's lots of data that supports that, but I don't know. I think the exciting part is there's going to be a lot more coming, and our state may be leading that as we get more and more data. So I don't know, it'd be interesting to see how it changes.
Definitely. And if you guys ever have cases that you want to talk about in this capacity, you're welcome to send them in and we'll go over everything. We got another question into the chat. And so it's when talking about the babies who were exposed to cocaine, why did it take 6 years to see the long-term effects? And is this related to the development of the frontal lobe?
Yeah, I think that's exactly what it was. So the frontal lobe doesn't really affect growth or eating or any of those physical development features. And if you think about it, if you go to your pediatrician, right, and as a parent, you're filling out all the checklists, no one starts asking you about school or emotional health. I mean, you kind of do, but most of the questions about where are you on your growth chart? How are you eating? And so some of that cocaine data may have not even, that was sort of before we asked more of the emotional, social questions to maybe pick up on it. But I think that was the shocking point. They actually early reported that it was normal. Like some of the early reports were that, oh, you can use as much cocaine as you want. We don't see any problems until the school data hit. And so, that's the other thing that sometimes happens is we think a kid is fine or they don't show outward signs of things, but they really are struggling. And so that executive functioning, anything that affects that frontal lobe, you're going to see once you start having academic demands. And so I think that's exactly what it is. And that pattern, again, has really borne out. And that's also, I think, a big difference in research. Like, how long can you follow a kid? You lose people, right? And if you had normal facial features and you didn't have some of those physical or motor abnormalities, you probably didn't even get care until you started having trouble, because that's when the problem started.
That's so interesting. It's sad interesting, but helpful. Do you have, or has anybody implemented these mental health emotional questions in earlier into intake and stuff now?
Yeah, they've redone a lot of the questionnaires through the American Academy of Pediatrics to ask more about sort of attachment and behaviors. And so, and a lot of so Amanda's done some work with sort of like PCIT and infants about even asking about attachment and bonding questions. I just don't think we asked those questions in the 80s, but people are definitely doing that. And they've modified some of those scales even for opiate exposures specifically. So absolutely, I think we're in a better place at looking for those things. Again, I'm not sure I've seen all that data. And again, everything seems to be a little delayed in my world, because sometimes I see them at 3 or 4 if they're really like hyper, but most of the kids don't get to me until they're 6 or 7 sometimes. So I don't know what you guys are seeing at community care. I think people are more likely to come get help. I am seeing people now kind of coming to care earlier than I think they used to. I mean, I would see sometimes teenagers that clearly had never had any interventions. Now I think they're getting younger and younger. So I think I think that's also been a real improvement in mental health. I think there is less stigma. People see it as more helping, and so I hope that will be a move to get these early intervention services.
Something I think we see because we are involved in the school-based behavioral health is that schools are more used to kind of facilitating this. And it doesn't mean they totally understand what we do as behavioral health. Sometimes we're like extra disciplinarians, but I think they are helping funnel kids with these issues to us earlier because they see behavioral issues and that kind of thing.
Yeah, I think part of the age at which we are able to intervene really depends on who has custody of the child. Definitely, anecdotally, I think that grandparents or foster care are more likely to seek early intervention, more so than maybe the biological parents. I think that's because of a lot of fear and stigma that the biological parents may have. And then just piggybacking on that, I was wondering about some of the opioid data. If you had any idea, Dr. Schweiger, if they had kind of looked at confounders, like, are they still in that environment? Is it nature versus nurture? Are they, are these folks that, is it strictly based upon the in utero, or is it also some of the early childhood environment as well?
Oh, it's all of it. It's both and, right? So yeah, the burden of if you continue to be exposed to that parent substance use, if you continue to, we know that those increase burdens. It's just really hard to, you can't like do a randomized control trial where you decide to like expose people to X amounts and follow them. That's unethical. So these are hot messes. And so the answer is all of those factors really do play a role, and the more burden you have in any one thing is the more general burden of illness. But that makes the data really hard, right? Like you can't, and I think this is why mental health is nebulous to a lot of people. They just want a straightforward black and white answer, when the answer is it is so multifactorial you can't wrap your head around it. But the treatment is too, right? Like you have to be thinking about all those things, and so at any point, can you intervene? But if you don't have that underlying sort of safe base and a stable environment, you're not going to get a whole lot, and you're going to get continued burden on attachment and mental health. So that's all been demonstrated. Again, I think the numbers are hard because every kid's different, and you've seen, you all have probably seen tons of kids with in utero exposure, and it could be incredibly mild to severe. It's just very hard to standardize that. And again, that comes back to, how much were they exposed to, when were they exposed to it, what were the specific child factors that may have protected or not protected, and they're all just so different. So it makes it hard to study interventions too, and know great data on the percentage of success, but the total answer is that early interventions across all modalities and establishing that safety and environment really do help. but it's hard to pick out from the data what intervention for each kid. So you still do a, what's the current problem and how do I intervene in that problem kind of approach, but it's tough.
I think it's hard. I think it's hard with the data too, because you can't identify the impacts on these children with opiates or with Suboxone, because now you're having, you know, parents who are exposed to, or babies that are exposed to multi-drugs in utero. And so it's very rare that you're coming across a parent that's utilizing just one specific drug. Whereas before, you know, you could find that, but it's very rare now. And even with Suboxone, if you have a relapse, you have to discount that. And so the numbers aren't really helping us with that.
That's a super good point. I hate it, but we've come to the end of our time. And Lauren, this has just been spectacular and amazing session. I'm so thankful for all of you guys for engaging and participating. So our next session is going to be on the 17th. We have decided to dedicate that session to cases, which really relies on all of you guys out there to send us cases. Anything you have questions about, anything you've seen out of the ordinary, well, not even out of the ordinary, something you have a question about that came up during this COVID time, anything, you know, therapy, medication, what have you. So definitely send those in. You'll see the link in the recap email. Anybody who gets that email or who doesn't get that email can be forwarded. It's not just for the secure list serve or anything like that. I don't share something wild and crazy on my emails or anything. And I know I had something else, but now I can't remember. So I'll email you. Everybody have a wonderful day. And thank you again, Lauren.